So our session today is on practical solutions to reducing radiation exposure for the interventionalists. We talked about this yesterday and the day before a little bit in the course of seeing live cases. The ISET program committee really appreciates the support through an educational grant from the Occupational Radiation Safety and Interventional Fluoroscopy, ORSIF, to enable our focus in this incredible breakfast session. Before we get started, or as we get started, I just want to introduce our speakers in panel. Our speakers this morning will be Allison Sipley, who's to the right. She's a medical physicist at MCVI and Baptist Health. Dr. Ripal Gandhi, one of our program directors and leaders in interventional oncology. Dr. Erin Murphy, who is from Charlotte, North Carolina, and a vascular surgeon who's head of the venous and lymphatic program there. Dr. Bill Gray, who's another one of the program directors, and he's the cardiovascular service line leader at Mainline Health. Dr. Bob Foster, who, let's see, Bob's on this side. Bob is actually the founder of ORSIF and the chief medical officer and a big driver of the increasing interest as we look at occupational hazards. Dr. Dan Clare, who is the chief of vascular surgery at Vanderbilt. Jay Matthews, an interventional cardiologist from Sarasota. And Dr. Constantino Pena, who is another program director, part of our organization, obviously a leader in our organization, and an interventional radiologist from MCVI. Let's see. So one of the things we're trying to do is sort of move the needle on radiation protection. ORSIF is dedicated to this, of course, and I think we sense that there's more and more interest in doing the best that we can to protect ourselves as well as our patients. So we want to understand radiation reduction and protection efforts for the interventionalists in daily practice, regardless of the location. Explore how imaging modifications affect radiation protection. Analyze currently available personal and disposable shielding technologies and solutions, let's say, to minimize exposure risk, and assess the capabilities of current scatter protection systems and potential innovations for use. Just to get things started, we want to just assess what the common level of knowledge is. And if you could take a look at this question, what are the yearly allowable radiation exposure amounts in the U.S.? And it's a multiple choice question. Okay, what I see so far is that 50+% said 5 rems, but we had 15% at 10. At 2 and 1 also had about 8 or 10%, and about 10% of the audience is unsure. Okay, don't be afraid, you'll be anonymous on this one. Do you routinely wear your radiation badge for every case, or badges? Okay, so almost 40% are brave enough to admit that they don't. Okay. It's a pleasure for me to welcome Allison Sipley, who's a diagnostic medical physicist, to the podium for the first presentation.
Good morning. Thank you, Dr. Katzen. As he mentioned, I am a diagnostic medical physicist as well as the radiation safety officer for several hospitals in the South Florida region. This morning, my talk is titled, What Should Be Realistic Expectations from Radiation Reduction and Protection Initiatives? As he kind of already mentioned, the learning objectives for this morning are to understand current radiation reduction and protection efforts for the interventionalists in daily practice, as well as to recognize the protection that lead aprons and leaded accessories offer in the IR suite. Okay, so before I talk about the expectations of radiation protection, I want to first remind you what we are protecting in the first place. So on the left here, I have a list of the radiosensitivity of organs and tissues listed in order of highest radiosensitivity to lowest radiosensitivity. And at the top of the list, one of the most radiosensitive tissues is the red bone marrow. In adults, the active bone marrow is primarily found in the pelvis, ribs, spine. There's also some active bone marrow in the ends of the long bones in the arms and legs, as well as in the top of the skull. Also on the list for highest radiosensitivity are going to be the colon, lung, and stomach, as well as the breast tissue. Next, we have the reproductive organs, both male and female. And then slightly lower on the radiosensitivity list, we have the bladder, liver, thyroid, and eyes. The eyes in particular have kind of moved up on the list in the last several decades as we've learned basically what radioactivity and exposure does to the lens of the eye. Actually, the International Commission on Radiation Protection has actually drastically reduced the recommended limits to the lens of the eye in the last 10 years or so, based on what we know about cataracts. Radiation-induced cataracts occur in a very particular part of the eye as opposed to naturally occurring cataracts. And so their recommendations went from 15,000 millirem to roughly 2,000 millirem per year, which is a huge reduction. And then at the lower end of the list, again, not non-radiosensitive, just lower radiosensitivity, is going to be the brain, bone surfaces, salivary glands, and skin. Okay, so now that we know what we are protecting, let's look at some of the lead aprons and accessories that are available to you in the IR suite. We have the full apron, which comes in common thicknesses of 0.25 to 0.5 millimeters of lead equivalent. Just so that everyone is aware, the minimum lead requirement for body lead is 0.25 millimeters of lead equivalency. So you really won't find anything lower than that on the market. Next, we have the vest and skirt combination, which is probably the most common lead that we see most physicians wearing who are using fluoroscopy. And this generally comes with a front and a back specification. Something to be careful of is that usually the front gives a lead equivalency, assuming full wraparound coverage, right? So this is where well-fitting lead comes into play. If your lead is not covering you double in the front on both the top and the bottom, then you're not actually receiving that coverage, right? So in this example, the front was listed as 0.5 millimeters. If your lead does not fully cover all the way around the front, then there are portions that are only covered by 0.25. Okay, and that's usually applicable to both the vest and the skirt. We also have the thyroid shield, which generally comes in about 0.5 millimeter lead thickness. That's pretty standard. Some physicians are wearing sleeves. Sleeves come in various shapes and sizes. If you are, as I mentioned in the previous slide, there is some active bone marrow in the shoulder area, so this would offer that additional coverage. If you're willing to take the weight, I would recommend more of like a cap sleeve rather than like the full length sleeve. We also have the leaded glasses. Leaded glasses have gotten a little bit better in the last few years, offering better coverage. If you are wearing leaded glasses, they should have side shields installed for better overall coverage. And then we also have the radiation cap. Again, radiation caps come in various shapes and sizes. There's even some disposable ones on the market. Some additional lead aprons and accessories that you may see around the department. We have rolling lead shields, ceiling suspended shields, table mounted drapes. These generally start around 0.5 millimeters of lead. We also have the mobile lead wall barriers that sometimes you'll see the anesthesiologist sitting behind. And these generally start at 1 millimeter of lead equivalency. So now that I've kind of explained all of these lead thicknesses, what does that mean for you, right? So I'm going to show you. I put together a chart of what your lead can do for you. This is the scatter reduction versus various lead thicknesses and at different tube potentials or tube energies. Now, I'm sure this information was probably available somewhere, but I am a physicist and I enjoy experiments. So I actually took some lead that was lying around the radiology department and I put them to the test. I set up a phantom on a table and I put some lead near where the operator would be standing. And I measured in front of the lead and behind the lead. And so what we found is what we would expect, right? Greatest protection is offered at the greatest thickness at the lowest energy, right? And as you can see, 1 millimeter of lead basically blocks about 99% of radiation scatter at all energies, right? Even at the higher energies. But what I want you to notice here is that also at the lowest level of lead protection at the 0.25 millimeter of lead equivalency, we still saw about an 85% scatter reduction, even at the higher energies. So this is an example of a dosimetry report. This is an actual dosimetry report from an interventional radiology department that I work for. I have removed all identifying information because I don't know if I have a permission to share. But what I want you to see here is this is an example of a 2 dosimeter badge system. I know 40% of you said that you're not wearing your badges. I don't like to hear that during every case, but this is a good example to show you what your lead is doing for you. So these physicians are wearing 2 badges, one at the chest beneath the lead and one at the collar over the lead. And so what we see here, or what we would expect from the previous testing, is that you would expect to see the collar badge about 85 to 90% lower than the chest badge. Sorry, I take that back. You would expect to see the chest badge, I apologize, which is worn under the lead, about 85 to 90% lower than the collar badge, which is worn above the lead. I apologize for the confusion. And basically, that's exactly what we see. In the first example, the chest badge is about 87% lower radiation dose than the collar badge. And in the second example, the chest badge was about 94% lower than the collar badge. And so I really recommend the 2 badge system because it gives you a very clear indication of what your lead is doing for you. And if you do have any concerns or questions about that, I urge you to take a look at your department's dosimetry reports. It'll give you a lot of useful information. And that's all for me today.
Thank you, Allison. When was the last time radiation protection was discussed in your lab or department? Within the last 6 months, 34% have indicated. Within the past year, 25%. So over half have had some sort of discussion. 10% talked about it last week. That's great. And 30% said never, to my knowledge. So obviously an unmet need. In terms of bringing this up. And this is more of a question about you personally. Do you feel equipped, meaning either yourself or have the resources to advocate for radiation safety improvements in your institution? Yes or no? Okay, so it's about 60-40. 58 say yes, 58%, and 42% say no. So there's an opportunity there. And finally, what percentage of scatter radiation in your work environment do you believe could be avoided with better tools? Again, we heard from Allison about efficacy, but there's a lot more to it than just the thickness of the lead, of course. So just from your own understanding, okay. It's interesting, still changing. Okay. So over 75%, in the 76 to 100% reduction, 35% of you believe that you could avoid really up to 100% of scatter in that group. That's the largest number, and it's pretty evenly distributed between the other categories. So there's a diversity of opinion, but certainly the largest group is, at the very least, optimistic. Our next presentation is and we can talk about this during the discussion. The plan is to have our lectures and save your questions or send your questions in now, and we'll have a panel discussion to follow. So it's a pleasure to welcome Ripal Gandhi, who's going to share his thoughts on enhancing radiation protection through imaging modifications. Ripal?
Thanks, Barry. So it's my pleasure to be here, and I'm going to launch right into this. So as we all know, imaging procedures are a leading source of radiation exposure, and as the number of procedures that we're doing and the complexity increases, it's a growing concern. This is kind of a scary statistic I saw here. The interventional physicians receive more radiation dose than a nuclear power plant workers on average. So I think in order to decrease radiation exposure, it really need a team approach. And we're going to go through various ways. We'll start with some basic things and then some more newer and more complex and advanced techniques. I like this quote: working with radiation is like keeping a pet tiger in your living room. It can be great as long as you don't take your eye off of them for 1 minute. I think that's really critical here. Sometimes we don't see the radiation, and if we're not paying attention to it, it can be extremely dangerous. We're all aware about the deterministic and stochastic effects. Again, deterministic effects have a threshold dose. Stochastic do not, the most concerning which is cancer. And there's a wide variety of health exposure effects from radiation. The one that I find to be most concerning are some of the malignancies, especially including brain tumors. While this is not definitive data, it's still concerning enough for me. So our goals here are to minimize radiation exposure to the patient, physician, and staff without increasing the risk of the procedure, maintaining image quality while utilizing techniques to decrease the overall radiation exposure, and then always utilizing ALARA. So very, very basic things, but some things that can really extremely useful when we're doing procedures every single day. Time, distance, and shielding. Less imaging, less exposure. If we increase the distance from the radiation field, we are decreasing the exposure by 1/4. So that is extremely powerful way of decreasing our radiation exposure. And then, of course, shielding is very, very important. And Allison described some of the importance of the lead in nice detail here. So this is some stuff that she already talked about, so I'm going to skip some of this. There are obviously a bunch of shields. This is a Terminator, a device that Dr. Katzen is utilizing, or I think maybe that's, and then this is one of these newer zero gravity systems. But there's a variety of these systems out there, and I think one of the future speakers is going to get into this in much more detail, so I'm not going to focus too much on this. Some of the very basic things that I see all the time. Here's the lead shield. I see, often our trainees are not utilizing it appropriately. Bring it all the way down to the patient. Very, very basic. Practices that we could utilize almost every single day. Collimate. Sometimes we're really involved. I'll even tell our technologists, feel free to collimate. Minimize use of magnification if you don't need it. Limit DSA and decrease the frame rate when you don't need increased frames. Utilization of filters, and then don't be at lead foot. You don't know how many times I'll see our residents or fellows pressing down on the pedal, not looking at the screen. Only press. It seems very, very basic, but it's surprising how often I see it. Angulations increase the exposure significantly. And for example, if you take a 60-degree angulation and compare it to a 30-degree angulation, it's 3 times the radiation exposure. Now, clearly, a lot of procedures that we do, some of the complex procedures that we do require angulation of the image intensifier, but try to minimize it if you can. Other important practices when you're doing angiography on multiple stations, make sure you limit the overlap, decrease the KVP and increase MA if you need to in order to improve the image quality. Pay attention to those 5-minute marks for the radiation. And finally, utilize power injections when you can, in a lot of these situations, we'll step outside of the room altogether. There's no need to be exposed to that radiation. Utilization of pulse fluoroscopy. Obviously, sometimes you need to increase the pulses depending on the image quality, but decrease it when you don't. This is probably the thing that bugs me the most. I see this every single day when I'm walking by the rooms. Decrease the distance between the image intensifier and the patient. A very, very easy and safe way, but it's so surprising how many people just have the II sitting up there. That really increases the scatter radiation significantly. Obviously keep your hands out of the field. Something that you might not think of, but if you're going to utilize these lead gloves, and there might be certain circumstances where it's appropriate, but you do end up actually paradoxically increasing the radiation exposure overall, because basically the II is trying to penetrate through the lead and therefore increasing the KVP and MA. Real-time dose monitoring tools can be extremely valuable. There's DoseAware, RaySafe. I'm sure there's other systems out there, but I think this really allows you to have real-time feedback on some of these different techniques and see how they actually real-time decrease your radiation exposure during the procedure. High-quality imaging with low X-ray dose. There's a variety of systems out there. The system we happen to have in our lab is a Philips system, and you can't tell the difference here if you're looking at the top image and the bottom image. The bottom image utilizes a special protocol called Clarity IQ, and this technology basically utilizes real-time pixel shift, motion compensation, noise reduction algorithms, and image enhancement. And through all these, you get pretty much the exact same image quality, but you have over 60% radiation exposure reduction. 3D overlay and image fusion can be extremely valuable. You basically take your preoperative CTA or MRA, and you basically fuse it to fluoroscopy, which allows for real-time evaluation. If you move the table or the image intensifier, everything will move in turn. And this can help you reduce radiation exposure during complex procedures. Cone beam CT, we utilize cone beam CT for a variety of procedures. If you're not comfortable with it or if you don't have it, I encourage you to take a look at it because we utilize it for things such as embolization procedures where you're trying to get into complex vessels. Instead of doing multiple procedures or multiple angulations to find the exact angle, this will actually help identify the actual vessel for you. And then you have a real-time roadmap, and you could definitely significantly reduce your radiation exposure. Similarly, you could utilize cone beam CT for other complex procedures. This happens to be a type 2 endoleak embolization. You could utilize it for tumor ablations and various other treatments as well. Something a little bit newer, fiber optic navigation. Basically, this utilizes light without the need for fluoroscopy. So this Lumi guide with fiber optic real shape technology, also known as FORS, has been shown in aortic procedures, which can be done significantly faster by 37%, but however, reducing the radiation exposure by 70%. And you could also utilize some of this technology with off-the-shelf catheters as well. So, this is something that's coming and really has the potential to decrease our radiation exposure. Finally, robotics. We've been involved in looking at several different robotic systems, and with one of these earlier robotic systems, we kind of just looked at our own internal data, and we're easily reducing the radiation exposure by 50%. But ideally, you could probably get much more than that. So, in conclusion, even small differences, small changes in radiation exposure on a daily during your daily workload can really reduce your accumulated radiation dose over a 30-year period. Obviously, follow a LARA principle and time, distance, and shielding. And then clearly the newer technologies, including some of this endovascular navigation, 3D overlay, fiber optic catheters, as well as AI, may help us further reduce the radiation exposure. And I think our goal really should be zero radiation. But I think, it's going to be a while before we get there. But I really liked this editorial from JSky by Dr. Rizek. And they basically asked, zero radiation in the cardiac cath lab, an aspiration goal or a moral imperative, and I think it should be both. I'll stop there. Thank you.
Thank you very much, Ripple. Thank you very much. Brief question before our next presentation. If we can put that question up, please. And those of you who have those of you who have asked questions, we're saving them for the discussion. So continue to send your questions in. Have you adopted any new radiation protection tools in the last year? Okay, again, if you have this on your app, you're seeing the results, but 53% said no, 22% looking into it in the future, and 25% yes. So again, identifying some opportunities. It's a pleasure for me to introduce Dr. Erin Murphy, who's going to give our next presentation on advances in personal and disposable shielding protection. Erin?
Yeah, thank you, Barry, and thanks for covering such an important topic. Some of this overlaps a little bit. Certainly these radiation risks are real. We want to keep our risks down as much as you can. We talked about ALARA. I think we have come fairly far since some of us trained. I remember stepping back from the machines thinking, I heard this was safer, and being told if you want to be a vascular surgeon, you shouldn't be afraid of radiation, get back up there. So I think we've all progressed beyond that, right? But there are more things to do. We just heard about imaging modifications. I feel like I still pick things up. I'm still learning some things. We don't pay as much attention to it as we should. And certainly there's personal and disposable protection shielding that we can also use. We're going to start kind of with the wearables, and we've covered a bit of this, but that's your lead-apron shielding, your hats, your thyroid shields, your glasses. There are even gloves. There's creams. We won't go through all of it, but again, we're making progress, right? Although I would love to see Jay Matthews show up to the cardiac cath lab wearing that. Pretty scary. But that's, I guess, where we started. We do have holes, though, we do have holes currently in some of our protection, and there are some advances that are addressing some of this. So I'm going to cover a couple of those to show you what's up there, some of the things coming up that I wasn't even aware of necessarily. And there are still orthopedic injuries associated with some of the wearing and the weight of this lead every day. And I know that some of my colleagues have back issues already. And these are, just some of the things that are coming our way. So orthopedic issues are pretty common now. 48% in the survey for the ACC said they had orthopedic issues. 70% said that they were caused by work. 50% said it may contribute to early retirement. When we look at, by job, it's not just the doctors, it's also the nurses and techs. And I feel, we need to be having these conversations with them too. They need to be protected as well. As we spend more time in the labs and we get older, certainly this is affecting us more. The societies are starting to pay attention to this too, which is good to get, some backing. Sky put out the multi-society position statement saying that the goal is really this completely radiation-safe environment that does still mitigate the risk of these orthopedic consequences for those wearing lead. There's been these suspended radiation protection systems around for a while now. I remember this was kind of coming out when I was, towards the end of my training. There's, mixed feelings on it. I think there can be some feeling of being a little bit inhibited in movements, but it does certainly protect your back and does help during some of these particularly long cases. Newer to the field is these G-lift type device. What do you call them? Like gowns that have these exoskeletons that transfer that weight from your shoulders and your upper back down to your hips. There's been it's on the newer side, but there's been some docs who have switched to this with good results. There's a trial out of University of North Carolina in Wilmington, which showed that there was significantly less back strain, particularly in these upper back muscles. I'm actually curious to take a look at this. Also, you can do lower weight leads. These are more comfortable. They're certainly easier to move in, but you do lose some of that protection. But as our first speaker talked about, you don't lose that much. And if you combine it with good shielding, this may be, something we can do as we improve our techniques and our shielding external that we're not wearing. The benefits of this, of course, is reduced pain and increased ease of movement during cases. Other gaps in protection include, the breast tissue, the legs and joints, knees, brain, eyes, hands. There's other things that we still need to address. The breast and axilla area, 1 in 8 women get breast cancer. The risk in men is 1%, but radiotechs have a 16% higher risk. Orthosurgeons, 4% higher risk. This is very highly sensitive tissue. If you remember from the figure we showed nicely in that first speaker's presentation, it's certainly dose dependent, so we should be focusing on keeping this low. And of course, the left side is more commonly exposed to the radiation. The tail of this breast extends into the axillary region, and most of our lead looks like that. It's only actually in the past few years that I started to wear something that was a little bit more protective. And I think, again, it's an area we don't really talk about this. I don't feel that it's addressed as much as it should be. So they do have protection that you can add sleeves on that will cover that whole axillary region and that upper arm. It is a little bit to get used to, I think, but I think it's worth it. And the data shows that this kind of shielding can significantly block radiation to that area. So other technology, we have, certainly glasses, already commented on, is to make sure you have the side shielding because it does reduce the radiation overall to the eyes and brain. They do have caps. One thing that's interesting is most of the radiation that we get in that area probably comes up through the face and jaw. And this sort of thing may provide some coverage, but it doesn't really block all of that, right? So there is some newer technology coming, which has more face shielding. Which I think can block a good portion of that upcoming radiation and scatter. Some of my colleagues are currently wearing these and having their skirts made longer to cover their knees to prevent orthopedic issues. There are gloves available. I've never used them. I think that they tend to be a little too thick for a lot of what we're doing with wires. But one interesting fact, if you do use them or any of those creams, is you want to keep them out of the field of view, because if you put them in the field of view, and it can actually increase the radiation dosage that from the machine self-adjusting. Other options are these shielding options, and we'll go through just a couple of these, but they have I think we're all familiar with the rad pad. They have a newer one, Radix. Protection sheets and draping, I've not had those used, but again, you have to be careful not to put them in the field of view of the machines, or you can actually inadvertently be increasing dosing. And then these mobile and static shield technologies, some of which we've seen. The rad pad, I've been using, I think, since I was a resident. It does reduce scatter, again, keep them out of the field. And the Radix has a newer version of these kind of disposable shields, which has a panel that goes up and kind of covers the gap, especially when you have those mobile shields you're putting in, and there's always like a gap at the bottom. You can use this to cover that and block further radiation scatter. Mobile shields on the wheels, there's newer systems, Rampart, Protego, Agnest. I think it's worth looking into these if you're looking at the next step in your cath labs. Certainly, we've seen that these shielding technologies do work. A lot of times when I see my colleagues, like we have the shields that are mounted from the ceiling, we have the skirts from the machine. We do have some of this, but when I'm looking and stepping into my partner's room to say hello, they're often over in that corner and tucked over there, not on the table. I say things to my colleagues, and I think we should all be kind of watching each other's back on this, make sure we get used to paying attention. This is Kenny Rosefield. I like this quote: from a practical, moral, and risk mitigation perspective, every institution performing fluoro procedures with X-ray equipment should equip labs with enhanced radiation shielding solutions. Thank you.
Thank you very much, Erin. Again, we'll have some discussion after this final presentation by Bill Gray on current and future scatter protection systems.
Thanks, Barry. Editorially, we've, over the last half a century, done a very reasonable experiment. We've had a population of operators stand in front of radiation and wear 30, 40 pounds of lead. And I think the experiment has demonstrated that both from a cancer and orthopedic perspective, it's no longer a viable solution. And what I'm going to talk about here are mechanisms to mitigate both situations, which is scatter, oncologic issues, as well as orthopedic ones. I think we owe it to the next generation of operators to take it seriously. So we've talked a lot about the operator and the radiation that they receive, but it's important to also recognize, and Erin touched on this at the end of her procedure, at the end of her talk, that in the room there are other significant people. I'm an interventional cardiologist. I do vascular, I do structural. I use a lot of anesthesia and a lot of echocardiography at the head of the table, and those people get a lot of radiation scatter. And the folks in the room, while they may not have as much as the operators and the anesthesiologists, they're in the room every day, all day. We may have a block day, Monday, Wednesday, and Friday. Most of us are not in the lab every day. So importantly, they need protection as well. And all the things we're talking about here are probably impractical for them. All the additional shielding you talked about. I mean, your old picture is starting to look like your new picture. So I think, again, scatter is critical to prevent it and for the room. We've already talked about the radiation risks and orthopedic injuries. I'm not going to dwell on that. I do want to go through 4 systems that are currently in place and in development. So the first one is the Protego modular system. This is a system, as you can see, has a series of shields which envelop the patient around basically from the abdomen all the way around, so that the X-ray you can do coronary intervention pretty reliably with a very low rate of scatter. It also has augmented shield drapes as well, aprons at the bottom there, and you can see that there's a kind of a mobile unit and the modular pieces. All of the systems I'm going to talk about here, except one, has modularity incorporated into it. I know people who have used this. It does work reasonably well. It isolates the patient, and it limits the kind of procedures you can do to coronary in the main. So the next is the Rampart system. The Rampart has, again, a modular approach to radiation scatter protection, really enhancing the table in a complete fashion, allowing more flexibility for the different types of procedures. There are different types of Rampart shielding systems: mobile, a fixed floor model, and a fixed ceiling model. And it is designed to be versatile for multiple types of procedures and workflows, and can accommodate structural, PCI, EP procedures in the cardiac lab, aortic intervention, peripheral, and neurovascular intervention. This is an example of the shield with a soft shield that comes on top of the patient. So it's a little bit like the RadPad, but more extensive and in a different area. So you can move it around as much as you need to. Where there's evidence, I'm going to show you the evidence. These are the evidence from the Rampart device. Over 99% radiation attenuation with significant more protection than traditional lead aprons and shields. It has much more superiority over the standard lead aprons and shields. And I think, it's great that we see these kind of data, because we need to make decisions on objective criterion. The second is the EGNEST product family. It's similar in terms of its approach, in the sense that it's setting up multiple segments of radiation reduction and scatter, and all of these systems largely protect both the operators and the staffs, which, as I mentioned at the beginning of this talk, is important. I'll talk about the aprons in a minute, but these are all, again, you'll see the family of products here, which allow for, again, a wide variety of procedures and a lot more flexibility in the room. The lead apron issue is an important one. I know you talked about the protection and the various thicknesses of aprons. I have seen and worn, as just a demonstration, 0.125 thickness, and it's like a rain jacket. It's really significantly less heavy than what we currently wear today. It's meaningful. And I'll talk a minute about what the goal really should be in terms of what we need to wear. Here's the EGNEST Complete, which is the name of the system. It's a ceiling-mounted lead shield with 99% protection, one sterile drape for the patient. The Radiofemoral drapes are also available, and real-time dosimetry, so dosimetry is included in this product. And here's the ScatterPro disposable drape, which is really quite extensive. And you can see here there's a radial component as well. So again, where there's data, I want to show it. It turns out that for this system, we are achieving what we want to achieve, which is to reduce radiation scatter for everybody in the room. And you can see the various positions here have significant reduction in scatter. And here's another example of just comparing what the U.S. max annual dose is, the standard shielding, and then the operators in an egg nest environment. The last one I want to talk about is the radiation dynamic smart shield. The others are static radiation capture. This one attempts to capture the scatter at the source. There's an upper and lower shield which is attached to both the generator and the image intensifier. Each shield has a series of tungsten segments which lower. You'll see. I'll show you a video in a minute. Which lower and envelop the patient and seal around the patient. The control for this is fully functionally integrated into the C-arm and at the bedside control, so there's not a lot of fussing around with it. There are 3 levels of safety, including the proximity and contact sensors, which detect the patient in the table, so there's no crushing the patient or anything like that. There's a hover mode, so there's a protection mode and there's a hover mode, so you can lift it slightly, the flaps come up, and you can pan the table while still getting protection. And then, as I said, it's a dynamic system. You have full and immediate access to the patient. You'll have to wade through a bunch of protection shielding. This is there it goes. So you see here, these are the tungsten arms coming down, and then the flaps enveloping the patient. This allows any number of different angles without any reduction in radiation protection. And these are the various angles demonstrated. Even lateral can be quite protected, and pretty much any imagined position of the II can be accommodated. Therefore, most of the procedures can also be accommodated. So different from the other devices, because this device is attached to the imaging system, it's a Class 2 device, which means that they will be developing FDA quality data sets. It blocks scatter radiation at the source, as we talked about, and provides more than 90% of protection in the room. That data will be emerging shortly. And it has immediate patient access, as I mentioned before, for any emergencies that might occur, and has a full integration into the workflow. This, I don't know if anybody knows Richie Slofmitz at St. Francis. Richie does 20 to 30 cases a day. He's been doing it for over 40 years. Richie has a kind of a test beta site installation, and he moves very quickly, as you can imagine. And Richie doesn't tolerate things that he doesn't like very much, but he has been very happy with this overall. So in summary, there are multiple scatter protection systems currently or soon to be available in the United States. Shed the lead is an aspirational goal, but it may require state regulatory changes. Light lead is a very likely and I think acceptable endpoint from both the radiation protection and orthopedic perspective. System acceptance, whatever system we choose, will hinge on the ease of use, flexibilities for procedures, and setup times. And I want to say that all of these systems, no matter which one you use, will take us another second or two to engage. And I think the days of ignoring radiation scatter and just wheeling through a procedure without any cognitive kind of recognition of what's going on are hopefully coming to a close. We have to give a little more time and more attention, possibly some ease of navigation, but we need to achieve some more superior protection than we have today. Thank you very much.
Thank you, Bill, and thanks to all of our speakers. We have obviously time for discussion and questions, so I would encourage any of you in the audience to submit those questions. First thing, as we begin this discussion, we're interested in your thoughts on who's actually responsible in your institution, or who you think should be responsible for this whole problem from an institutional point of view, or wherever you're working. the radiation safety officer, you as a physician leader, an external body, state regulatory or OSHA or other federal agencies, or should there be guidelines developed and implemented? Okay. So over half believe the institution, through the radiation safety officer, should be there, be the responsible party, and only 31% feel the physician should have the responsibility. Okay, so I think we have a few minutes for discussion. I'd like to ask Dr. Foster, perhaps to start. Tell us briefly about ORSIF and how, what the goals of the organization are. We really appreciate you supporting this meeting, of course, and how you personally perhaps got engaged.
Well, first of all, congratulations. I think that, having this caliber of speakers and this attendance is huge. I think we're beginning to see some momentum and interest in this area that's just long overdue. Our focus as physicians have been on patients and where they should be, but we shouldn't have to do that at the expense of our own health. And so there really has not been a lot of opportunity now to improve radiation protection and orthopedic protection and eye protection, head protection, all these other areas, and now we have them. So I think it's the purpose of ORSIF is to really raise awareness, kind of an educational platform, a one-stop shop where you can go and you can get information about what are these new technologies that are coming out, having platforms that you can go get CE and more education for you and your staff, just to raise awareness. Because if you look at who's responsible, it's really, it's almost everybody in that list. We are somewhat responsible. We need to have knowledge of the work environment that we work in every day. But there's also needs to be enforcers like the radiation safety officers, but there needs to be some guidelines and regulations, which we're working on now.
Okay, thank you. I wanted to ask Dr. Matthews, you work in both the hospital environment and the ambulatory care facility. Do you think there's an equal attention to radiation protection in those two venues? I don't know whether they're administratively the same or not, but well, what about the variability when you work site to site?
I actually think that in the outpatient world, where the physicians have a lot more autonomy and decision-making in terms of what gets put into those labs, we actually do a better job. And, I've struggled even for the last 3 years to bring in additional radiation protection. It keeps getting cut as a line item from the capital budget. So, we've struggled with radiation protection in the hospital. It is not the same. It should be the same, and we should have them be equal. But unfortunately, we lack a lot of power and autonomy, I think, in the hospital settings.
We don't have a hospital administrator on the panel, but I can tell you, having been in that position, generally hospitals don't want to talk in public about radiation, and they certainly don't want to publicize the efforts that they're putting in to reduce radiation for fear that patients will be afraid. And what's this about radiation? So there's that inherent trouble with trying to get hospitals to really recognize. And then sometimes there's a separation between who we're trying to protect, the operator or the staff, and or both. And that's kind of been a communication problem. Dan?
One of the things that's neat about this topic is it's one of the things that all of the specialties that deal with fluoroscopy on a routine basis agree about. We all want protection for us and our patients, and I think we need to take advantage of that as we deal with hospital administrators to together go as a group. I think it can be really beneficial if you have your cardiologists, your interventional radiologists, and your vascular surgeons and cardiac surgeons, honestly, together, sending the same message to hospital administrators.
We have a couple of questions from the audience I'm going to throw out to everybody. One of the first one, maybe Allison, you can address this. What are the current guidelines for pregnant interventional radiologists? Should we avoid radiation in the first place, in the first trimester? Sorry. And are there any studies on this?
So pregnant interventional radiologists, you have the option to declare pregnancy. I would always recommend that you declare pregnancy. At that point, you would be issued a fetal monitoring badge that would be worn at the waist level under any lead skirt that you would be offered. Also on the market are maternity sized skirts. So I would recommend that you would request that from your institution for a better fit. As I mentioned, with tops and bottoms, separate pieces of lead, if they do not fully wrap around the front, you are not getting the coverage that is stated and expected from that lead. As far as occupational radiation limits, when you do declare pregnancy, your occupational limit drops to 10% of what it previously was. So from that first polling question, the limit for occupational workers is 5 rem or 5,000 millirem per year. As a declared pregnant occupational worker, your limit drops to 500 millirem for the duration of the pregnancy. And really, we like to see it at 50 millirem per month. Should you reduce your workload is dependent on what your monthly radiation badges are showing. And so that's a tough question to answer. That's more of a individual question, I guess.
Okay, thank you. There's another interesting question to everybody on the panel, asking who, if anyone on the panel, has suffered a radiation-induced injury, if you're willing to say, and if so, when did it happen? Thank you, from a scared trainee. So let's talk about the future a little bit, if I could just editorial comment. And maybe someone can talk about frequency of injuries if we have that data. But the Society of Interventional Radiology, you heard about cataracts and posterior cataracts. Probably about a decade ago, surveyed at the annual meeting a large number of interventional radiologists with varying degrees of experience. And that's how those posterior cataracts were actually discovered and published. But that was, these were asymptomatic and just sort of evidence of and it was temporally related, that is, in terms of years of practice. But let's talk about the fear factor for a second, maybe. You know, you're in a big institution. We have young trainees. We have medical students. We're talking, and this is exactly what I was mentioning regarding the hospital's concern. How afraid should people be that are in training, and do they want to? Is it still worth looking at a career in image-guided therapy?
Look, you're leading me to that answer, and that is, you know, it's still, you know, we do everything we can to limit, and the amount of exposure is very small, and you should feel safe. But I'm going to kind of deflect the question a little bit to one of my big areas, and that is we have technology now that should be able to measure real time what you're getting after every case, and that knowledge, I think, is really important. And, you know, you may get a dosimetry reading that was taken over a month, and we'll receive that report 8 weeks later or 6 weeks later. It's hard to really act on it. And to me, I think one of the areas that we need to move on is being able to, you know, whether it's every piece of equipment when you walk in, have a way that you're recording what you're getting at that particular time, and that gets, you know, accumulated and added on so you know what's going on. Going back to your question, look, I think we need as much awareness as we can. I think it's still very safe of what we do as a trainee. See, you know, what you get even over the years. It's really important that you're aware of it and trying to minimize it as much as you can. But I think it's something that's still very safe.
I think for the trainees, I mean, I think we went through an era where people did fluoroscopy with no lead and no protection. That's how it got started. And those very early physicians and people who work with radiation did suffer significantly from bone marrow-related disease and different types of cancers. And I think just with the protection that's been involved over the past decades, that's been greatly reduced. That's separate from orthopedic problems. Jay, did you want to?
Yeah, I mean, I think for the trainees, you know, when we talk about the radiation effects, I mean, it's over the long term. And obviously the technologies have improved significantly where there's massive dose reduction compared to when I first started training to what I get now. There's a big reduction. However, what has not changed are the orthopedic issues. And this is an immediate effect and what you guys need to be aware of. Because, you know, for many of us too, we've all had injuries, back injuries and whatnot too. If I do a day of cases, I can't feel my legs at the end of the day. And that's a big problem. And it's going to reduce our overall longevity even sooner than the radiation-related injuries. I would encourage you all to watch the documentary Scattered Denial. Dr. Kyriakis, is very forthright in terms of what he went through. And I think it's very sobering because, we take these steps to reduce our radiation dose, wear protection, but then we're also suffering because of that protection itself, and there's got to be better solutions.
Yeah, related to the first question, I've had 3 back operations, and I kept working through it all, but I have to feel that there's some connection with that over the years. There was a request for the ORSIF website. I'm not sure we had it on the slides anywhere. Would you like to share that?
Yeah, so one of the things that we're doing, it'll be the first international symposium on radiation protection coming in September. And I think that's going to be really good. We're going to get speakers from all over the country to really dive deep into this. How does it affect your DNA? How where are we going forward? And getting more education from our radiation safety officers, from regulators, for how do we make a difference? Because that's the biggest leak now is how do we get these systems into our hospitals so that we can all get protected.
Okay, and I think if you're looking for the organization, just search ORSIF and they should be able to find you, right? Yeah. So we want to leave everybody in the audience with something they can go back tomorrow and do in their own program. So I'm just going to ask the panel real quick, if you're going to do one thing, leaving ISET and going back and trying to improve whatever the situation is your institution. Tino?
I think in our institution, what I would try to push is having, recurrent sessions, recurrent educational sessions, being people aware of radiation, what the dose is, and what we need to do, and like small things that we can do right off the bat. And I think that's something that I would continue to push.
Okay. Again, this is advice for them in their own institutions.
Yeah, adjust settings, collimate, mag out as much as possible.
Simple things that we don't do, use your shielding. Don't put them like my partners do in the back of the room, step back from the table. And one thing I'm going to do is actually start meeting with some of these companies. I didn't know some of this stuff existed, and I go to these conferences all the time. So, do a little research, look up some of these, products on the slides, and just start getting some education on what's available.
I've actually already initiated conversations in my institution around scatter protection systems. We started to do some evaluations of those. As most people's hospitals are, ours is pinching pennies these days. So I've already had conversations with my foundation about philanthropic support for purchase of these things. And new labs that go in will almost certainly have these one of these radiation scatter protection systems built into them. And so for us, it's a transition that's already kind of underway in the early stages.
What should we do, Allison?
Wear your dosimetry badges, pick them up on time, turn them in on time. You won't know if your radiation protection efforts are successful if you don't know what your radiation dose is in the first place. So as the radiation safety officer on the panel, of course, that would be my recommendation, in addition to everything else that everyone is suggesting.
Ripple?
I think some of these real-time dosimeters are extremely valuable. You could see real-time, what is, moving back 2 feet? What is that going to do? Or what, utilizing collimators, how is that decreasing your radiation exposure? That could really influence behavior in the real time. So something I would definitely consider.
Yeah, and at MCVI, we had that for a while, and everybody in the room could see their real time. And so if you were 2 or 3 people at the table, you learned immediately if you took one step to the right or left, whatever, you could really drop your dose. So I think that's an important technology we should see advance.
I think understanding radiation, I think, is a big thing, and just beginning to look for those gaps. For me, 2 back surgeries, kind of like you, it's an issue. So you've got to find a solution that is good for you and your team and the types of procedures that you do, because not all, it's not all one fits all. You've got to find what's right for you.
Dr. Claire?
So 3 quick things. Remember the power of distance. It's more important than almost anything else we do. Number 2, limit subtraction usage. It's an order of magnitude increased. So if you can use cine or just fluoroscopy to image something without subtraction, use subtraction sparingly. And then third, I would say align the specialties for when you obtain new equipment to mandate that that new equipment include the purchase of radiation scatter protection. We're getting 8 new Rampart systems at Vanderbilt in our cath lab, and that's actually allowed us as vascular surgeons to say, we want this for our room together. So aligning physicians along that line, I think, is very helpful.
Okay, great. I guess I'll throw one more in. Go and look at the frame rates that are set on your equipment. Well, you may or may not know, and just drop them all by 1 frame a second. You'll immediately have an impact on your scatter and radiation to the patient, and so on and so forth. Okay, well, I'd like to again thank ORSIF for supporting this program and getting us all together to talk about it, and hopefully everyone in the audience found something useful from this. Thanks to our outstanding panel.